Are we able to see the timer anywhere? Yeah. Good evening, all. Warm greetings from Society for Study of Pain, Pune. I welcome all delegates for today's academic meet by Society for Study of Pain, SSPP, on Usg Shoulder Interventions. I know, though this topic is discussed time and again, it always creates interest in all pain physicians. For today's meet, we have with us well-known pain physician from Bhubaneswar, Dr. Rajendra Sahoo, as an expert faculty. Welcome, Dr. Sahoo. We missed you in our UST workshop in October. So we took this opportunity to invite you for the meet. Today's presentation will be done by Sanjog Mekewar, a pain physician at Wakat, and the session will be moderated by Dr. Archana. Dr. Sarita Swami, President SSPP, has conveyed her inability to attend the meet, but she has extended her wishes for the meet. So without wasting much time, let's start the meet. Over to you, Archana.
Yes, ma'am. Thank you. Good evening, everyone. I'm Dr. Archana Nankar. I'm a pain physician practicing currently in Pune, and I'll be moderating today's session. So our topic for today is ultrasound interventions in shoulder joint and how I do it by Dr. Sanjog. So as we all know that the ultrasound machine is an integral part of pain clinic today. It not only helps us in diagnosing various pain conditions, but also helps us in doing interventions more accurately and safely. However, to use the ultrasound machine properly in our day-to-day pain practice, we require to have a thorough knowledge of the anatomy and sonoanatomy. Keeping this in mind, so let's focus on today's topic, that is shoulder pain. So shoulder pain is a very common condition seen in a pain clinic. And today we are going to go through, discuss step-by-step examination of the shoulder joint using ultrasound, as well as how to diagnose with various pathological conditions of the shoulder joint using sonography, and what treatment can be offered to the patient for those pathologies with the aid of an ultrasound machine. So in order to start the session, first let me invite Dr. Rajendra Sahoo.
I am there.
Yes, sir.
Thank you.
Yes, sir. Good evening, sir. Sahoo sir does not need any introduction. He is a well-known pain physician all over India, and he is known for his skills in ultrasound, using ultrasound. So he is a consultant pain and palliative care medicine at Kalinga Institute of Medical Sciences, Bhubaneswar. He is also the only pain physician in India to have 2 MSK and ultrasound pain intervention certificate by WIP and ASRA. His experience of he has experience of starting pain clinic at 3 hospitals. He has 40 publications and 4 book chapters to his name. He is also faculty at has been a faculty at ESRA pain meeting and cadaveric workshop Madrid, and he is a regular faculty at various national level pain and regional anesthesia conferences. So welcome, Dr. Sahoo, sir. And let me introduce today's speaker, a young and dynamic pain physician from Pune, Dr. Sanjog Mekewar. So he is attached to various hospitals in Pune, including Sahyadri Hospital, Sainath Hospital, Gavde Hospital, and also he's a visiting consultant at BJ Medical College and Sassoon Hospital, Pune. And he's a director of Jurisha Pain Management Center, Pune. He has 3 scientific research paper publications to his name, plus 1 national patent Respiro I to his name. And his special interest includes regenerative medicine and spine endoscopy. So hand over to you, Dr. Sanjog.
Thank you, Dr. Archana, for a kind introduction. You have to stop sharing your screen, then I can share my screen. Thanks. Okay. Can you see my screen? Can you see my screen, Dr. Archana?
Yes.
Yes, it's visible.
Okay. So good evening, everyone. So the topic for today that I'm going to talk about for the next 30 to 40 minutes is ultrasound guided interventions for shoulder pain, how I do it. So that my topic will include some slides on the normal shoulder anatomy and some common pathologies related to the shoulder pain. Now my algorithm that I follow for diagnosis of shoulder pain. Then I'll talk about what is the step-by-step approach that I use for during the ultrasound of the shoulder joint. Then I'll share some pics and some videos of some common shoulder pathologies that you can guess. Then I'll talk about some of the common interventions that we do for the shoulder pain patients, and then I'll end the talk with a take-home message. So before starting this talk, the one point that we all should remember about shoulder joint is that shoulder is not a weight-bearing joint. So all the degenerative changes which are common in the weight-bearing joints, like knee joint or ankle joint, they are less common in the shoulder joint. So one important factor about shoulder joint is that it is a very mobile joint. It is the most mobile joint of the body. So the pathologies that we see are related to this property of the shoulder joint. So we will quickly go through the normal shoulder joint anatomy, and we'll see the structures from inside out. So first, talking about the bones, as you all know, there are 3 bones which together form the shoulder joint, which includes the humerus, the scapula, and the clavicles. Then the joints which are present around the shoulder include the glenohumeral joint, which is the main joint that we're going to talk about today. It is a joint which is ball and socket type of joint. formed between the head of the humerus and the glenoid cavity of the scapula. Now, the glenoid cavity of the scapula is a shallow cavity, so which makes the joint very unstable. So this shallow cavity is reinforced by what is called as the glenoid labrum, which is a fibrocartilaginous structure which deepens the shoulder cavity and stabilizes the joint. So medially it is attached to the rim of the glenoid cavity. What are the other joints which are present around the shoulder joint? These include the acromioclavicular joint, which is present with the acromion process of the scapula and the clavicle, and the sternoclavicular joint between the sternum and the clavicle. Both are gliding type of joints which facilitate movement. One more important joint that I want to talk about today is the scapulothoracic joint. So it is not a joint per se, but the relative motion, the relative movement between the scapula and the thoracic cage actually helps in the normal mobilization of the shoulder joint, and it is very important that we have to remember. Next comes, we have already talked about the glenoid labrum. Next comes the joint capsule. Now the joint capsule has two membranes, a fibrous membrane and a synovial membrane. So fibrous membrane is attached on the medial side to the rim of the glenoid cavity and the glenoid labrum, and on the lateral side is attached to the anatomical neck of the humerus. While the synovial membrane extends beyond this area medially, inferiorly, and laterally. So medially it extends as the subcoracoid recess, inferiorly it extends as the axillary recess, and laterally it extends as a recess around the long head of biceps tendon. So this is important because whenever there is a joint effusion or joint inflammation in various conditions, we can actually see the extension of the inflammation or effusion in these recesses. Then comes the ligament. So ligaments, the main function of shoulder ligaments is to increase the stability of the joint. So anteriorly, the stability is reinforced with the glenohumeral ligament, which has three parts, the superior, middle, and inferior part. Superiorly, this joint is supported by the coracohumeral ligament and the coracoacromial ligament. So coracohumeral ligament we'll talk about when you're talking about the adhesive capsulitis. Now coracoacromial ligament between the choroid process and the acromion process. So it is basically not joining two bones, but the two processes of the same bones. And it forms a kind of an arch from below which the supraspinatus tendon, it enters from posterior to anterior or lateral side. The other ligaments are the acromioclavicular ligament and the coracoclavicular ligament. Then coming to the rotator cuff muscles and tendons. So rotator cuff muscles, these are basically the muscles around the shoulder joint which are mainly responsible for the motility that we see around the shoulder joint. And what are these muscles? These are the supraspinatus, which arises from the suprascapular fossa and attaches to the superior facet of the greater tubercle. The infraspinatus, which arises from the inferior fossa and attaches to the middle facet, and the teres minor, which attaches to the inferior facet of the greater tubercle. Then there is subscapular muscle, which arises from the subscapular fossa and attaches to the lesser tubercle of the humerus. Now, what are other muscles and tendons of importance that we should know about while understanding the anatomy of shoulder joint? These include the long head of biceps tendon. So long head of biceps tendon actually enters the shoulder joint cavity through the bicipital groove and then attaches over the tubercle which is present on the superior aspect of the glenoid cavity. Then we should also know that there is a deltoid muscle, there are pectoral muscles, serratus anterior, serratus posterior, rhomboid. So knowledge about these muscles is important because the incoordinated action between these muscles actually can lead to the generation. They can be lead to incoordinated movements and later the shoulder pain. Then coming to the bursae are basically the fluid-filled spaces which are present between the tendons and the bones and facilitate the free movement of the tendons. And the most important of them is the subacromial subdeltoid bursa, which is present below the acromion and the supraspinatus tendon. And the subcoracoid bursa, which is present between the subscapularis and the coracoid process. Then coming to the nerve supply. So when talking about nerve supply, we have to know about the articular branches, which are derived from the suprascapular, axillary, and the lateral pectoral nerves. And these articular branches are the targets during the pooled radiofrequency ablation that we do for the shoulder joint pain. And the other nerves of importance are the subscapular, spinal accessory, long thoracic, and dorsal scapular nerves. So this is the list of the common shoulder pathologies that we have to address in our clinics in day-to-day practice. So these include the fractures of the bones forming the shoulder joint. So pain can arise because of all these pathologies: fractures, dislocations, joint pathologies like arthritis, osteoarthritis, inflammatory septic, capsular pathologies like adhesive capsulitis, capsular laxity, shoulder joint ligament tears, rotator cuff pathologies like tears, tendinitis, tendinopathies, impingement syndrome, long head of biceps tendon pathologies like tenosynovitis, tendinitis, tendinopathies, tears, subluxation, bursitis, glenoid labral tears, nerve entrapment syndromes, scapular dyskinesia. So these are the long list of shoulder pathologies. So with so many pathologies, how to go about diagnosing the case of shoulder pain? So this is a short algorithm that I generally follow in my clinic, which helps me actually to rule out any other cause of shoulder pain first. So whenever a patient of shoulder pain comes to me, history is the first thing and the most important thing that we have to take. Simple thing like age of the patient will give you an idea about what to expect from the patient. Like if the patient is old age, more than 60 years, patient generally have osteoarthritis. Between 40 to 60 years, patient generally has rotator cuff tendinopathies. Between 20 to 40, generally have tendinitis or bursitis. So this is how the age factor plays. The other questions that we have to ask are: is it acute pain? It is chronic pain? Is there any history of recent or old trauma? We have to also ask about the relevant medical histories. After the history and the history of the patient, the first thing that I do is to rule out if the pain is arising from the neck. So we have to do a quick examination of the neck. If there is any pain during the neck movements, we have to expand the examination of neck. We should never confuse the pain arising from neck or from the shoulder. The next thing, what I tell my patient is, I generally ask them to just expose the upper back and the shoulders on both sides to just do a quick inspection and palpation. So during that, what we have to do, we have to rule out the red flags, any causes of any signs of any inflammation, redness. We have to look for any bilateral symmetry, atrophy or hypertrophy of the muscles. We have to see if there is any winging of scapula, location of pain, and we have to look for any points of tenderness. So this is very important. So we should not ever overcome or leave these steps. I just had last month, I just had one patient who came to me with upper back and shoulder pain. He was diagnosed to have trigger points by some other physicians. He was given one injection for trigger point release. When I just did a quick inspection, what I saw was there was a winging of the scapula. The medial border of the scapula was winging. And there was atrophy of the serratus anterior muscle also. So I diagnosed him, I labeled him as a case of scapular dyskinesia and started with the physiotherapy and trigger point release, whatever trigger points were present on the medial aspect, on the rhomboids and the trapezius. But 1 week later, patient came and there was no relief. There was not a single percent relief in pain. And but one thing that I observed in the last visit was a slight cough that patient was having, and that cough was persistent even 1 week after I have seen the patient. So further inquiry led to a history that yes, he was having cough since last 15 to 20 days. And I just asked him to get the CT scan of the thorax, and what we got, what the diagnosis completely changed. So he was actually having upper lobe carcinoma of the lung, and that was actually causing the compression of the lateral or long thoracic nerve, and which lead to this presentation. So these history and inspection palpation is very important. Should never leave this. Then if the patient comes to you with acute sharp pain and it is very difficult even to examine, then it gives us a suspicion that it is acute bursitis. Then we proceed to the shoulder examination. Explain the shoulder examination in detail. We all already know this, and just telling you the algorithm how to go about it. So the first thing that I do is passive external rotation. If it is limited, it gives us an idea that is a capsular problem. I'll ask the patient, I'll do the active abduction of the patient. If there is painful, get an idea that it is a subacromial impingement. Then we can do the knee stress and the Hawkins-Kennedy test. Then we have to look for any rotator cuff pathologies. So there are some tests for each of the muscles. For supraspinatus and infraspinatus, there are empty can test and Job's test. For the teres minor, we have the hornblower sign. For the subscapularis, we have lift-off test and Napoleon. The AC joint pathologies, we have the scarf test or the cross shoulder reduction test. For biceps tendon pathologies, we have speed test and redness test. So what we have to remember is these tests, all these tests have a sensitivity of 40 to 80%, but the specificity of only 20 to 30%. So these tests only gives us an idea that they help us to narrow down on the structures that may be the problematic areas. So after this examination of the shoulder of the patient, what we proceed to, and after narrowing down what may be the possible pathologies, we progress to the ultrasound of the shoulder. So I generally divide the ultrasound examination of shoulder in 3 steps: the anterior examination, superior examination, and the examination of the posterior aspect. So this is a short video. On the right side of this video, you'll see the placement of the probes, and on the left side, you'll see the images that you'll see on the ultrasound. And I'll slowly explain how to go about the examination of the shoulder. Okay. Yeah. So we are starting the examination from the anterior aspect of the shoulder. The probe is placed over the shaft of the humerus, and we can see the just starting of the formation of the bicipital groove. So as we go up, we are seeing the proper formation of the bicipital groove. Okay. Yeah. There is coming up of the hyperechoic structure here, which we can see. This is the biceps tendon. Okay, this is for all this examination, this is the medial aspect. On the left side is the medial aspect. On the right side is the lateral aspect. So medially, what we see is the subscapularis tendon. This is the lesser tubercle. This is the greater tubercle. I'll just have a picture ahead in which I will explain. Yeah. Yes. So here we can see this is the subscapularis, this is the lesser tubercle, this is the greater tubercle, this is the biceps tendon, this is the transverse humeral ligament, this is the deltoid muscle that we can see here. So what are pathologies, or what are things that we have to see? We have to look for any calcific deposits in the inside the tendon, which can be seen in the patient of tendinopathies. We have to see for any joint effusion, tenosynovitis that we can see here. We have to look for the placement of the position of the ascending branch of the circumflex humeral artery. So all these things are we have to see here. So here we can see the pulsations of the ascending branch of the circumflex humeral artery. On color, we can reconfirm the position of the artery. Yes. Now from this position, we have seen the cross-section view. Now we will go to the longitudinal view. We will see the longitudinal view of the biceps tendon. So this is the biceps tendon. It is very nice fibrillary pattern of the tendon can be seen. And as we go superiorly, we will see the intra-articular part of the tendon. Here there is the chances of a lot of anisotropy, and we have to do a lot of rocking and movement of the probe to actually see the fibers. Here we can see the attachment into the acetabular superior aspect of the acetabulum. Okay, so this completes the examination of the biceps tendon per se. Then we have again placed the probe on the anterior aspect where the tendon was there, and I'm moving my probe a bit medially. So on placing the probe on a bit medial aspect, what we see is these structures. So what are these structures? This is the subscapularis tendon. This is the lesser tubercle of the humerus. This is the coracoid process. We will see a subcoracoid bursa here. If it is present, this is the deltoid muscle. Okay. Yes. The next thing that I do in these patients is to see the dynamic examination of these structures. So what we have to tell the patient? We have to tell the patient to do the external and internal rotation. So we can see nice movement of the subscapularis tendon going below the coracoid process. There is no any effusion, no any synovitis, a component of synovitis. There is free movement of the tendon till 5 o'clock position. Then we have to see, yes. Then we have to see the tendon in total, means in the longitudinal view and also in the cross-sectional view. We have to see the fibrillar pattern. We have to look out for any tendinopathy. We have to look for any tear which may be present there. This is again the same movements here. One more thing that is seen during this testing is you have to look for any subluxation of the biceps tendon. So the biceps tendon which is present here, this is the external rotation. In the internal, yeah, the biceps tendon is present here. So during external rotation, we have to actually see if the tendon is getting displaced out of the bicipital groove, which may be seen in the patients with injuries or the rotator cuff injuries. Then I have changed the position to the cross-sectional view, and here we can see the cross-section view of the subscapularis muscle. So here it is of importance that we will not see the fibrillary pattern. Here the pattern we'll see is a multi-pennate pattern. So you should not confuse this. So this is the multi-pennate pattern of the subscapularis muscle. It should not be confused with the tendinopathy. Yeah. Now I again place my probe to the original position, that is around the biceps tendon. And what I do is I go a bit superior. And then you start getting this kind of picture. So we get a proper oval biceps tendon. It has converted into an elliptical form, and it is going on the medial aspect. Right. So we have turned our, we placed our probe like this. Yes. So this is what is called as this is at this position, what we'll see is the rotator cuff interval. So what is rotator cuff interval? Rotator cuff interval is a triangular space which is present between the subscapularis, the supraspinatus tendons, and the base of the coracoid process. The roof of this rotator cuff interval is formed by the coracohumeral ligament, and it is the structure that passes through this is the biceps tendon. And actually this space was developed. So here you can actually see on the medial aspect the subscapularis, on the lateral aspect the supraspinatus. This is the biceps tendon. This is the cortical surface of the humerus. On the superior aspect, we will see the coracohumeral ligament, right? And on the medial aspect, here will be the presence of the superior glenohumeral ligament. So coracohumeral ligament and glenohumeral ligament actually form a kind of a sling, which stabilizes the biceps tendon in the bicipital groove. So actually this rotator cuff interval was identified for the arthroscopic surgeries, because there are no rotator cuff muscles here. So the chances of injury to that muscles was minimized if you enter through this rotator cuff interval. Next, what I do is from again that rotator cuff interval position, I move superiorly, and what we see is the tendon of supraspinatus. I go further on the superior aspect till I reach the acromion process. Yes, so on the medial aspect, you will see the acromion. This is the supraspinatus tendon. And I ask the patient to just do a abduction of the arm. So if the patients are having painful arch syndrome, we will see a kind of an impingement here. It can be because of the SASD bursa, it can be because of the supraspinatus tendinopathy, but this motion will be painful and we can diagnose through this test. Yes. So next, just by moving from that position, just moving the probe a bit medially, what we get is the acromioclavicular joint. Yes. So we have to identify all the structures which can be seen here. So this includes on the medial aspect, we will see the clavicle. On the lateral aspect, we will see the acromion. This is the acromioclavicular ligament. Just below it is the capsule. This is the joint space. We will have a cartilage here. And whatever structure that we are seeing, the echogenicity that we are seeing is the echogenicity of the supraspinatus tendon, because it goes below this arch basically. But by doing the cross abduction, okay, Yes. So by doing this motions cross adduction test, we'll see the movement of the acromioclavicular joint, and if there are any increased movement, it can be a reason for the painful AC joint. The next will be the examination of the supraspinatus tendon. So for that, we ask the patient to place his hand in the back pocket. This is the modified cross position, and it helps to bring the supraspinatus come out in front of the acromion, and it makes the examination of the supraspinatus tendon easy. Okay, so this is the probe position, and so we start the examination of supraspinatus near the rotator, where there is a tendon of the. So this is the biceps tendon. So most of the pathologies or the tears of the supraspinatus are present near to this biceps tendon. So we always start the examination near to the biceps tendon, and then we go superiorly. We go from medial to lateral, and we'll examine for the tendinopathy. So this is a picture that we get in this position. What all things we are seeing? We are seeing the skin, subcutaneous tissue, deltoid muscle. This is the subdeltoid subacromion bursa. This is the supraspinatus tendon, and this is the articular cartilage, and this is the cortical surface of the humerus. So these are the different layers that we see here. Yes. Again, here I'm doing the examination going medial to lateral, then inferior to superior. One more thing that you have to remember is if you go to superior or posterior, then you start getting the fibers of infraspinatus. Now I rotated the probe, and now I'm confirming or examining the supraspinatus tendon in cross-section view from medial to lateral. Yes. Then this is the anterior and the superior examination. Then we go to the posterior exam. So posteriorly, what we see? Posteriorly, first we again see the supraspinatus muscle. So here we can see that this is the spine of the scapula. Above that will be the supraspinatus, and below this will be the infraspinatus and teres minor. So first we examine in the longitudinal view, then we examine in the cross-sectional view. So this is the longitudinal view. Yes. So we can see on the lateral aspect, what we are getting is the acromion, again, the acromion process. So we will not be able to see anything below the acromion process. Yes, now I have rotated, and then I'm examining going medially. From here, what we have started seeing is the levator scapulae muscle. We can trace it to the transverse process of the cervical vertebra, upper four vertebra. Then we will place the probe below the spinous process, and then we go laterally. We'll see the infraspinatus muscle, longitudinal view. On reaching laterally, this is the cortical surface of the humerus. These are some fibers of teres minor that are coming here. Then we go a bit down on the lateral margin of the scapula and then trace upwards. These are the fibers of the teres minor. As we go laterally, we will again see the joint. These are the infraspinatus, deltoid, teres minor, some fibers of teres minor. Yes. So next is the examination of the joint. So I'll start my examination here by placing the probe on the spinous process and just go on the inferior aspect. So on just coming inferiorly, what we see is a notch-like kind of a thing. So this is the spinoglenoid notch that we commonly talk about, and it consists of the suprascapular nerve and vessels, which actually pass through this and then give the articular branch on the lateral side and other muscular branches to the supraspinatus and spinatus. So this is the area. So from here, just on the lateral side, what we get to see is this is the notch, this is the acetabulum. This hyperechogenic structure that we are seeing is the labrum. This is the cortical surface of the humerus. This is the infraspinatus muscle. So whenever we are doing interventions in the joint, we have to do here. We have to avoid injecting into the acetabulum. Yes. Okay. Okay. So these extra two things that I've just shown is just this is the head of the humerus. This is the shaft of the humerus, and here we can see the circumflex humeral artery, the axillary nerve. These are the structures. But this is one thing that we'll talk about later is the SHAC block, that is shoulder anterior capsule block, which is now being practiced for the peri-op analgesia in the shoulder joint procedures. So I'll talk in the later next slide. So this is how we go about the ultrasound examination of the shoulder. Now we'll progress to some of the common pathologies that we can see. And I'll give you, since this is not a two-way communication, there will not be two-way communication. I'll give 1 or 2 seconds after each slide or each pick so that you can guess in your minds what may be the pathology. Okay, so these are the two. Here we can see. Okay.
Bicipital tendinitis.
Yes, so this is bicipital tendinitis, tenosynovitis basically. And you can see the biceps tendon, bicipital groove, and a lot of effusion around the joint. Here on the right side, you can see again the same thing, biceps tendon, joint tenosynovitis. We can see in the longitudinal view also. Yes, so the collection of fluid around the biceps tendon. Yes, so these two picks again. Okay, so on the first pick, what we can see is, yes, definitely there is an effusion around the biceps tendon, but there are speckles of these calcific deposits inside the biceps tendon. So this can be a calcific tendinopathy, which we associated with the effusion around the biceps tendon. And on the right side, we can see the fibrillar pattern of the tendon is lost. There is edema, there is neovascularization. So this is mainly some trauma to the tendon has occurred, and there are some degenerative changes, the tendinopathy kind of presentation associated with effusion. Okay, these two slides. Okay, so on the left side, we have basically the biceps tendon, and we can see there is a tear which is present in the biceps tendon. Okay, and on the right side, this I have included because actually this was my patient who had adhesive capsulitis. We can see that there is restricted movement, external rotation. But actually this patient was advised surgery, and he was told that he is having subluxation of the long head of biceps. On doing the dynamic examination, we can clearly see that there is no subluxation of the long head of biceps. So this is the advantage of USG that we have. Next. This is interesting. So this is the same view on both. We can see on the both sides, on the left and the right. But on the left, we can see that this is the subscapularis tendon. This is the coracoid process. This is the biceps tendon. So on internal rotation, we can actually see the subacromial bursae, the collection of fluid. And on this right side, what we are seeing is the subacromial recess that I talked about, the synovial recess that extends. So how to differentiate? So the subacromial, subcoracoid bursa, sorry, it does not communicate with the cavity, the joint cavity. But this we can see here, it is going down and it is communicating with the joint cavity. So this is how we differentiate between the recess, tenosynovitis basically, and the bursitis. Yes. So this is again on the left side a case of subcoracoid bursitis. And on the right, the patient actually presented with the shoulder pain, and he was having tear in the subscapular tendon. You can actually see the subscapular tendon tear here. Yes, this is again the same subscapular muscle, but what we are seeing here are the calcific tendinopathy that we can see inside the tendons. This is the degenerative neovascularization. So whenever there is a degeneration, there is formation of new vessels, and this can be seen on the color when we do the color, apply the color to the images. Okay. So this is basically the supraspinatus tendon. Yes, this is the SASD bursa, that we have SASD bursitis. Here also we can see the acromion process, deltoid, supraspinatus tendon, and SASD bursa. Basically, the case of bursitis. Okay. So these are again the pics of the supraspinatus tendon. Here we can see the hyperechoic structures which are present inside the tendon. These are basically the calcium deposits, and this is the calcific tendinopathy of the supraspinatus muscle. Here also we can see the calcium deposits in the supraspinatus tendon. Both are the cases of calcific tendinopathy. Okay. So on the left side, we are seeing the supraspinatus tendon. This is the cortical surface, and this is the cortical surface tear that can be seen there. The cortical irregularity can also be seen here, and extension of the tear in the substance of the supraspinatus. Here also we can see the cortical surface tear, and we can also see the other signs like the dip of the deltoid into the supraspinatus muscle. So this, on the left side, we can see that there is an intra-substance tear of the supraspinatus tendon. And on the right, it is you can see it is a complete tear of the supraspinatus tendon, extending between the bursal surface and the cortical surface. Again, on the left side, we can see that there is a complete tear of the supraspinatus tendon. Right side is also a case of complete tear of the supraspinatus tendon with a lot of tendinopathy. Okay. So here we are seeing the dynamic examination that we did for the subscapular muscle, subscapular tendon. So we can see that there is a restriction of the external rotation. So the movement of the subscapular tendon, the attachment of the subscapular tendon to the lesser tubercle should be till around 5 o'clock position. So there is a restriction of the external rotation, and this is the right side also we can see that there is severe restriction of the external rotation. This is the subscapularis. And there is hardly the movement of the lesser tubercle till 2 o'clock position. So these are the signs which are seen in the patients of adhesive capsulitis. Okay. So here we can see this is the biceps tendon. This is basically so this is the video and this is the image of the same video. Here we can see that there is a biceps tendon. It is elliptical shape. On the right side, there is the subscapularis. Left side, it is the supraspinatus muscle. And we can see the coracohumeral ligament here, which has thickened. And it is a sign which is seen in the patients of adhesive capsulitis. So on the left side here, in the left-sided image, we are seeing a patient.
Joint arthritis.
Yes, AC joint arthritis, AC joint effusion basically. And on the right side, it is basically a tear in the infraspinatus tendon. So this is the cortical surface posteriorly. This is the posterior examination, longitudinal view of the infraspinatus. So this is the tear near the insertion of the not near the insertion, but near the joint. This I've taken from Google. This is the case of a cyst in the spinoglenoid notch. So this is a very common thing that is that you can also read in the MRI reports, and it is seen in the patients with the tears of the glenoid labrum or injuries of the rotator cuff muscles, and because of which there is a release of the joint fluid outside the joint cavity and collection and formation of cyst here in the spinoglenoid notch, and it can lead to compression of the suprascapular nerve here. And because of which there can be paralysis of the supraspinatus muscle, and there can be atrophy of the muscle. So this completes our pathologies. Then we'll progress to the USG guided shoulder interventions that we commonly do for the patients of shoulder pain. This includes the long head of biceps tendon sheath injections, SSD bursa injection, subacromial bursa injection, AC joint injection, glenohumeral joint injection, rotator cuff interval, suprascapular nerve blocks, pulse radiofrequency, regenerative therapies, shack procedure, barbotage of the calcium. So these are some of the interventions. I'll discuss some of the interventions, common interventions that we generally do, and tell you how I do it to get the max benefits of the procedure. So for any procedure, what are the pre-procedure preparations that I do? So for any, so all the shoulder interventions, I generally do the interventions in lateral decubitus position. So I used to do the procedures in sitting position, but I had one or two incidences of vasovagal, and so I decided to do all the procedures in lateral position. Antibiotic prophylaxis, definitely if you are going inside the joint, always give the antibiotic prophylaxis. Aseptic precautions, coverage of the, apply cover to the ultrasound probe also. Take care of the ergonomics, right? The machine should be in front of your eyes, so everything should be in line. I use high frequency probe, 4 to 15 hertz is what I have in the Sahoo machine. Then before doing the procedure, before starting the procedure, always do the check scan. So this is very important. This will help you in actually completing with your procedure fast. And before starting the procedure, always do the image optimization, get the best images, best exposures, and then start the procedure. So the first procedure that I want to talk about is long head of biceps tendon sheath injection. So before doing this injection or before selection of the patient is very important. So you have to differentiate if the patient is having tenosynovitis or it is a tendinopathy, it is a tendinitis, because the results are good when the patient is suffering from tenosynovitis, and they're not that good when the patient is having tendinitis or tendinopathy. The target is the synovial sheath here, right? Injectate, I generally inject steroid if the patient is having only tenosynovitis. If there is tendinopathy or tendinitis, I go ahead with 5% extros or PRP, whatever is available. Injected volume is around 2 to 4 ml. And what the approach is, lateral to medial in plane approach, what I generally do. The thing that you have to be keeping in mind is avoid puncturing the ascending branch of the circumflex humeral artery, which is present. Successful injection, you'll injectate, you can see the injected surrounding the tendon, and there should not be any tendon swelling. I'll just demonstrate how I do the long end of biceps tendon sheath injection. So you can see the tendon here, you can see the effusion here, the bicipital groove here. So you'll feel a give way when you just puncture the transverse humeral ligament. You can see the nice spread of the drug, the displacement of the tendon. There is no inflammation of tendon. So these are the 2-3 things that have to be kept in mind. The next is the subacromial subdeltoid bursa injection. Again, you have to differentiate if it is an isolated bursitis or it is secondary to the rotator cuff pathology. The target is definitely the bursa, which is outlined by the peribursal fat. The injected I use is, if it is only bursitis, then I go ahead with the steroid injection. If it is associated with the tendinopathy or the rotator cuff tears, then I go ahead with 5% dextrose or PRP injections. The injected volume that I inject here is 4 to 5 ml. The approach is lateral to medial in plane approach. Here you have to avoid injecting steroid into the tendons. That is the most important. If you are using PRP, you are using dextrose, you can go into the substance of the tendon and you can inject to avoid injecting steroid into the tendons. Successful injection is when you see the spreading of the drug across the bursal plane. So this is the supraspinatus, this is the acromion, this is the cortical surface, this is the deltoid, this is the SAISD bursa, this is the needle coming from lateral to medial side. Yes, so I've reached into the bursa. So if you inject very low volumes, 0.5 ml, 1 ml, you will not actually see the expansion of this bursa. Here I've injected around 2 ml, so you can see the displacement. You can see the full dilatation of this bursa. Right. Next is the AC acromioclavicular joint injection. So again, indication is only diagnostic following trauma or in cases of AC joint osteoarthritis, inflammatory arthritis. Target is the acromioclavicular joint space. I normally inject steroid with 0.25% bupivacaine here. Injected volume is less, 1 to 2 ml max. Here I generally, this is a picture taken from Google. I didn't have a picture of this AC joint injection, but I generally do out of plane approach because it's easy, very superficial structure. Here it is a picture showing the inline approach with the needle into the joint. Here we have to avoid injecting too deep into the joint, because if you go too deep, we know that here it is the subacromial bursa, and you will end up injecting the drug into the subacromial bursa and not into the AC joint. So this is the only important thing that you have to take care. Next is the glenohumeral joint injection. So the indications for glenohumeral joint injection are adhesive capsulitis, osteoarthritis, inflammatory arthritis. There are two approaches. One is the posterior approach. Here we can go from medial to lateral or lateral to medial. Then there is a rotator cuff interval approach. I'll show, the video has all the three approaches. The injected includes the steroids or PRP with 0.25%, steroid with 0.25% or PRP depending on the indication. If the patient is having adhesive capsulitis, then what we do is the capsular hydrodilatation with normal saline. First, if I injecting steroid with bupivacaine, I generally inject around 10 ml of solution. If I'm doing the capsular hydrodilatation with NS, I'm generally injecting 20 to 30 ml into the joint. Here, what important thing that we have to consider is avoid injecting into the glenoid labrum. That is the most important thing. Otherwise, you'll end up injuring the glenoid labrum. Successful injection means there is spreading of the drug below the joint capsule. So here is the video. So first is this is the rotator cuff interval. This is the biceps tendon, right? So you'll go from lateral to medial. What we have to do is you have to come. You can actually go below the tendon or above the tendon. So I generally go above the tendon, just below the capsule and the CHL ligament. Here I'm not shown the spread of the drug, but this is the position. So this is the position. This is the black thing. This is the posterior approach. Here we can see the cortical surface, the glenoid labrum, the acetabulum, the glenoid labrum, and the cortical surface of the humerus. This is the infraspinatus. This is the needle coming from medial to lateral side. So this is the medial to lateral posterior approach. So we have to be at above the superior aspect of the glenoid labrum. We don't have to go inside the articular cartilage. And then we have to inject the drug. And we'll see the spread of the drug along just below the capsule. And there is lifting of the infraspinatus muscle. So this is same posterior approach, but lateral to medial side. So here is the cortical surface of the humerus. Yes. So this is the glenoid labrum. This is the cavity. We can see the nice filling up of the cavity, lifting of the infraspinatus muscle. Next procedure that we are going to talk about is the suprascapular nerve block or PRF, pulse radio frequency ablation. So again, indication when I do this procedure in the patients of adhesive capsulitis or tendinopathies which lead to chronic shoulder pain. Approach is what I do is mainly out of plane approach because it helps in doing the pulse radio frequency ablation also and giving the block also. Injected that I use is steroid with 0.25% bupivacaine. And for pulse radio frequency ablation, I generally do it at 42 degrees centigrade for 4 minutes. If I am giving the block, then I inject it around 6 to 8 ml of the solution. Here we have to avoid injury to the suprascapular artery, which is present just beside the suprascapular nerve. Successful injection, you'll see the lifting of the transverse scapular ligament. So here we can see this is the suprascapular notch. This is the transverse scapular ligament. This is the out of plane approach. We can see the needle coming here. We have to hit the bone. Then we have to, if you are doing the PRF, pulse radio frequency ablation, you have to stimulate, you have to identify. Generally, the acceptable stimulation that I accept, sensory stimulation, is at 0.3 or 0.4. So here you can see the lifting of the spread of the drug and the lifting of the ligament. And this is just, I have added just to show you the stimulation that we get while doing the pulse radio frequency ablation. Out of plane approach. Next is the regenerative medicine. So the indications are rotator cuff tears or tendinopathies and osteoarthritis. Injected is other 5% dextrose of platelet-rich plasma. Injected volume, generally I use 2 to 3 ml. Minimum 3 sessions is what I do for the rotator cuff tears. And what I use in PRP is a leukocyte-rich with hyaluronic acid platelet-rich plasma. So this is a video demonstrating a case of supraspinatus tear, cortical surface tear. So before giving the injection, what I do is a bit of a needling to create some short trauma and to break the calcifications which may be present there. And this is how we inject the PRP inside the tendon. So only 2 to 3 ml is sufficient for the tears. Now this is the shoulder anterior capsule procedure. So Dr. Felice Galusio is who have identified this procedure or invented this procedure. So this is a procedure which is used as a for the post-operative analgesia. It's basically interfacial and pericapsular space block. And the advantage of this block is that it is a peripheral block. So it is devoid of, so for normally for the shoulder procedures, what we give is cervical nerve root blocks, which have their own complications. So since this is a peripheral block, it is devoid of any complications of the cervical nerve root blocks. There is only blockage of the articular branches. So there is no motor blockade. So there is early rehabilitation of the patients. What we inject here is 10 to 15 ml of 0.2% ropivacaine, what they have advised. And we have to combine this with the suprascapular block posteriorly for effective analgesia. So the injection is done at 2 places. First is between the deltoid muscle and the subscapularis muscle here in the interfacial plane. And we have to advance the needle same way down, just anterior to the myotendinous junction of the subscapular muscle. So at here, just above the capsule though, so extracapsular. So we have to inject extracapsular and just at the junction of the capsule and the subscapularis. what studies have shown is that they cover all the anterior articular branches, and they are very helpful in giving good analgesia post-operative. So the take-home message that I will get from this presentation is that ultrasound as a diagnostic and therapeutic modality is a boon for the interventional pain physicians. The dynamic evaluation we have seen of the structures is what differentiates it with other modalities. The targeted treatment and the ultrasound guidance increases the efficiency and the success rate of the procedure. And we can also reevaluate after, if we have done the procedure, we can reevaluate the patient after 3 or 4 weeks in the follow-up visits, and we can see the progress, what is going on in the joint. And the most important thing, we can do these procedures in the OPD basis and daycare basis in our clinics, and it's very affordable for the patient. These are my references, and thank you. Since you can ask the question.
Thank you, Dr. Sanjog. Very detailed and excellent presentation by you. I would like to call upon Sahoo sir if he would like to add anything or any comments from him about.
Thank you, Sanjog. It was an excellent presentation. You have covered almost everything.
Thank you, sir.
Well, one thing which I noticed is about the antibiotic prophylaxis that you mentioned. It's an individual choice, but I think I just give antibiotic in 2 conditions. One is while doing a trigeminal RF and intradiscal procedure. Rest of the procedures, I don't do that antibiotic. I have never done that. During training, I never do that. I take utmost precautions for shoulder procedures, all the joints, clinic, sterile, proof, covering with a tegaderm or whatever thing is that. Even if the medications that use for dilution, I always take 100 ml of normal saline bottle. Fresh normal saline, I always use Gylocard, the preservative-free lidocaine. New bottle, not the used ones. Fresh bottles, fresh NS, fresh needles, all sterile procedure. Touch wood, no infection so far, which I am always worried. I clean it 4, 5, 6 times with chlorhexidine alcohol solution. So that is something whether you want to do or not. So again, we tend to do what we learn from our kind of training period, whatever we have observed. So
I do antibiotics only. Sorry, so I do antibiotics when I'm entering the joint, because I'm, if any joint is infected, then it becomes patient becomes a friend for 1-2 months.
Okay, so that is one which is getting outdated actually. To tell you the truth, you take the precaution, as much as you can. Even with surgeons, our surgeons friends, they use a lot of antibiotics, and also we get patient who had end up with infection with TK or other surgery also, isn't it?
Yes.
So and other thing, I think you have pretty much covered one thing. One thing I noticed about the rotator cuff interval approach that you did, your needle was coming from lateral to medial, and it appeared to me that you are going through, you possibly can go through the supraspinatus tendon. The lateral side is the supraspinatus, then is the biceps, longer of the biceps, and laterally is your subscapularis. It appeared that your needle might go through the anterior part of the supraspinatus tendon before ending up with the rotator cuff interval. So I'm not sure, but that is what it appeared to me. So that is one part of caution. Basically, if you want to do either go flat, just put your needle just below the coracohumeral ligament from lateral to medial. If you're doing, I often do from medial to lateral. So approach from the subscapularis side. So I just go just beneath that coracohumeral ligament and inject the medication.
So you do out of plane approach, RCA?
I always do in plane. Okay. One or very thin patient, apprehensive for the needle. Although I just give good local. Earlier I was using a 22 gauge spinal needle or kind of block needle. Recent times I have been using just the 22 or 21 gauge, hypodermic needle that comes with a 10 ml syringe. That is more than enough. I just drag it as much as I can to the medial side so that the distance is limited. So I can do that. Now that is again another cost saving kind of stuff. The other thing that I think just to summarize here, you told many things. Kind of to all. So basically, while doing shoulder two or three common things. First thing to look for is it an isolated shoulder pain, or is it pain coming from the neck, which is quite possible, especially in older individuals who might have pain from either cervical facets or even some kind of radiculopathy also. And it is quite possible that there is accompanied radiculopathy also. Now, oftentimes the patient tells that, okay, it goes beyond the elbow up to the forearm or even if the fingers, and there might be some kind of double cross syndrome in terms of carpal tunnel also. But then you have to find out which is the dominant pain. The shoulder is the dominant pain, not able to sleep on that side. They wake up in the night, and there is, of course, a restricted range of motion. So that is one thing to differentiate. And then just, you give a good sort of many different 15, 20 things. Just to summarize, I think the first and most important thing is the rotator cuff pathology, which can be either a tendinosis, tear, full or partial thickness tear, or a subacromial bursitis rotator cuff. Then the second can be glenohumeral joint disorder, which includes commonly see adhesive capsulitis or the frozen shoulder, and a GH arthritis, those kind of stuff, and AC joint. Those kind of more or less most commonly three things that we see, in addition to those calcific tendinitis, calcifications, sometimes the labral pathology, or even if cyst, perilabral cyst also, and other things. So that is one thing. I think most important part is the clinical examination. First and foremost, history, active range of motion, look for it, and then go for a passive range of motion. If your passive range of motion is impaired, then think of external rotation and the abduction is impaired, then highly likely it is adhesive capsulitis, and more so in the context of diabetes, thyroid, rheumatoid arthritis, so on. So that is one thing. And then if you are able to do a passive full range of motion, passive abduction is possible, albeit little painfully, then unlikely a frozen shoulder, then you can think of a rotator cuff pathology. And then you can do some, special test, either speed, ergason, empty can, to kind of think of, pin down your diagnosis. Is it a AC joint? Is it something bicep tendon, or is it a rotator cuff pathology in terms of either a tendinosis or can be bursitis, those things. And then subsequently, of course, the scanning helps to pinpoint kind of finalize your diagnosis. I often sit in front of the patient while doing the scan, so that they can move around the chair, so that gives a good view patient can see also. So yeah, I think pretty much you covered everything very nicely done. Huge sterile procedure. I think somebody is asking about the needle size. I think the needle size, anything, it can be a spinal needle. If you have a block needle, you want to see better, echogenic needle you can take. And even if, those 2021 gauge needles that comes with a 10 ml series, that is also good enough.
Okay, so thank you so much for your input. So there is one more question. Can we mix dextrose with bupivacaine or ropivacaine? Dr. Sanjog, would you like to answer this?
Generally, I mix dextrose. I mix dextrose with lignocaine and bupivacaine just to reduce, because after dextrose, some patients may get that inflammatory response and all those things. So I generally mix dextrose with lignocaine and bupivacaine for injecting. Actually, some people are even mixing a low dose of steroid, 10 milligrams, 5 milligrams steroid, and giving the total solution as a prolotherapy. So, but I don't add steroid, but I mix dextrose with local anesthetic. Sahoo sir.
Okay, thank you. Sahoo sir, do you want to add anything to this?
Well, I told earlier, I exclusively use lidocaine for all procedures. I do all the procedures in the OPD based. So play safe, so there is no added benefit of adding a bupivacaine and take some risk of rare LAST. So play safe, Log-G-Card, all the time for me, Log-G-Card. Just for prolotherapy, I just do a very tiny amount of lidocaine, most of them like 12.5% dextrose or sometimes 5%, but I just add 1 or 2 ml of lidocaine, no bupivacaine. Well, those bupivacaine I use only. I'm doing something, interfacial plain blocks like SAP block, all those blocks for the post-mastectomy pain syndromes, hernia patients, post-herniorrhaphy. Otherwise, it's lidocaine for me all the time. You can use any of them, but I think I just want to play safe. For that reason, I take lidocaine.
Okay, sir. Thank you.
Excuse me, can I ask a question?
Yes, sir.
Sahoo sir, I have a question actually. Can we predict the outcome of any procedure or surgery by doing prior dynamic examination of the shoulder, by knowing just kind of any kind of tear, how much is the tear or any of the fatty infiltration into the muscle? So can we predict the outcome of the treatment?
Well, with the ultrasound, I don't think you can predict the outcome, but you can differentiate whether you want to do any, your intervention is going to be beneficial or not. Suppose you see that it is going to be, is a kind of high grade or full thickness, complete tear. So it's better you don't touch that. Okay, it's not your territory. Basically, send to the patient. You don't want to add a bad name for doing 1 or 2 procedure. And even if the patient might be telling you, okay, let's go ahead with this procedure, I'm not keen for surgery. So those patients may later send kind of, a lot of bad names for you. So that way, if it's a full complete tear, I don't touch, I just send to the surgeon to do their job. In what I have seen in some of the patients, I think other things come into play, like, they have a good deltoid other muscles, they have kind of decent preserved range of motion with almost near total or full thickness supraspinatus tear, but they have significant pain, and those were kind of old, probably those are kind of degenerative tears. In those patients, neither the surgeon and the patient were never keen for the surgery. 60-65, the rehabilitation is a big issue for them. So they can come back to me. I do procedures, even joint or subacromial bursa cortisone injection also has helped for good 6-8 weeks. Pain has gone down, and then second time they come, you are in a position to win back their confidence. You can just try some PRP, if it is not complete with a retracted tendon. Well, if you see fatty infiltration, definitely I don't think they are going to get better with kind of your interventional treatment. The other part, coming to ultrasound, whether it can predict. One thing I have noticed with adhesive capsulitis is that patients who are insulin-dependent diabetes mellitus and their adhesive capsulitis, the response in them is not as good as compared with a non-insulin dependent diabetes mellitus or without diabetes mellitus patient with frozen shoulder. So those patients with intervention, actually the pain gets better, but their range of motion actually takes a long time to come, actually, especially the abduction part. Partly, I think the disease process itself, and most of the patients which I have noticed, they do not rigorously follow a exercise program, rehabilitation program. Actually, if they should be doing that under the supervision of a therapist, thrice a week or maybe 5 days a week, whatever it is, for 12 weeks, probably the results will be better. Once the pain goes down, these patients go back to work, some kind of lower middle class village people. So they do not follow that. So that is one thing I have noticed, and literature is very much about that also. So in those patients, I tell from the beginning, you may need 2 or 3 procedures, and you need to be very careful, very particular about your rehabilitation exercise. That is the most important part. If they're not going to do it, actually, it may not help.
Thank you, sir. Thank you.
Okay. Thank you, sir.
Archana, can I ask a question?
Yes. Go ahead.
Yes, Sahoo sir, while giving the suprascapular block, we say we avoid the artery, injury to the artery. But I guess there are 2 difficulties what usually we face. One is the artery is not that greatly visible always. And second thing, we have to do either PRF or the injectant just near to the artery, because the nerve lies very near to the artery. So how do we tackle this situation?
So that is a tricky question, actually. So, touch wood, it has never happened. So I usually come from medial to lateral. So the artery is usually on the lateral side. Oftentimes I take utmost. So also many things, let me clarify this. Many people talk about doing the procedure at the supraspinatus notch. So actually, we don't do at the notch. Actually, it is just little inferior, and once the nerve has come out of that notch itself, it travels in that suprascapular fossa before it enters, as it goes further lateral, before it winds around that spiny glenoid notch. So once you have just come down little inferior and cauda to that suprascapular notch itself, the injury to the artery is not there actually. So what I do, so you go from medial to lateral, always needle bevel facing towards the ultrasound probe. Once you reach the bone, touch the periosteum, make a 180-degree turn so that your bevel is facing towards the periosteum. So as you just inject a half ml of anything, it can be lidocaine or NS or anything, you can see that getting lifted, it's in that vicinity. It is not on the top of the ligament itself. So if it is on the superior part of the ligament, then you are not close to the nerve. So that way actually can avoid. The other thing is that, if you're worried about this artery, I think you can take a block needle like, the B-Brown block needles that we do. So that way you can again avoid instead of using a sharp needle. But coming to that artery part, we have never encountered. If you go too much of lateral or maybe on the surface of that ligament, possibly you can end up having an arterial injury or something like that. But I think it is not a big concern actually. Suppose we talk about a celiac plexus transaortic, we kind of puncture that big aorta with a small 22 gauge block needle, because of that intimal wall thickness, it kind of stops. Unless patients are on like anticoagulant or big things, I don't think any clinical significant hematoma or something can occur. I don't think something like that has been reported so far also. Have you come across anything like that, anything in your practice so far? Even if you think that you have punctured the artery, have you come across any kind of lateral complication, swelling in that area, anything present, Dr. Banga?
Not in the shoulder, but I have come across the huge hematoma around the knee after the USG guided. So
on the knee. Okay.
Yeah. Not into the shoulder, but knee. Okay. It was ultrasound guided, and then there was a huge hematoma. Okay. Post-operative, maybe 6-7 days back, and there was no any other reason, but the procedure was.
Was that from that some of those genicular branches getting punctured while doing that?
Yeah. Probably it was one of the superomedial genicular branch which got the punctured, and the patient classically told me that. On the day first, he had some swelling there, which was red, and then on the next day, the half of the thigh was initially there was ecchymosis, and then half of the thigh was completely ecchymotic.
Okay.
So it settled by a conservative therapy, but yes, I did probably injured one of the branch, and that was it.
But superomedial branch, sir, many times we get that artery puncture while doing the procedure.
Yes. So it is very rare. It's very rare, and even it was, I think, after 7 days of the procedure. But still, there is a chance to say that the procedure was the culprit.
Sir, I would like to ask one question. Sir, is hydrodilation of the shoulder a painful procedure? I mean, do you give a suprascapular nerve block before doing the hydrodilation, or we directly go for that?
It is not painful at all. It is a very safe procedure. So basically, so what do you do? Either approach either anterior rotator cuff interval approach or posterior joint. Typically we use around 5 to 6 ml of lidocaine and some 40 to 80 of dipomedrol, and rest is like normal saline. For the posterior, 20, 30 or 40 ml of normal saline. I use a little bit more if the abduction is really badly restricted. Then I use a little bit more saline, like 30 or 40. And for the anterior approach, 20 or 30, it is not at all painful. Give a good local, very smooth, very quick, very easy. No painful at all. Okay. One thing I have recently started doing is that those patients who have abduction is severely impaired. I do all these procedures in OPD, so I have started doing a suprascapular nerve block just to tide over the initial part of the pain post procedure, so that it can help in facilitating the rehabilitation process. I don't know the actual benefit of this. No trial has been done so far, actually, addition of these blocks. But there are a few papers comparing the anterior approach with the posterior approach in recent times. I think 2 or 3 RCTs have been published. They have found the anterior approach is little beneficial compared to posterior approach, obviously, because with the anterior approach, you see that is the area, the rotator cuff interval, that is the place where the capsule gets thickened, the CHL that gets thickened, there is a bit of hyperemia, increase in soft tissue at the rotator cuff interval. So when you inject, that possibly that inflammation part is taken care of that area. So, but both the procedures are equally good, rewarding. So it is not painful.
Okay, sir. Thank you.
Yeah, only painful is that you are going to do PRP. So if you're going to inject into the supraspinatus tendon, that is going to hurt, actually. So for that, you can possibly do a suprascapular nerve block, or like suppose you do a plantar fascia PRP, again a posterior tibial nerve block. They are followed by PRP, because needling into the tendon fascia and injecting that PRP itself is the most painful part, actually.
Okay, sir. Thank you. Any more questions? If anyone wants to ask.
There's question in the chat box. Can you explain capsular hydrodissection for frozen shoulder?
Okay, I thought it was capsular hydrodilatation only. Okay, can you explain capsular hydrodissection for shoulder?
No, it is hydrodilatation or hydrodistension.
Yes, sir. Yes, sir. That's what. So maybe
distension. So dissection is not one. So basically, the pathology in adhesive capsulitis of the frozen shoulder, it can be secondary to a chronic degenerative rotator cuff also, but that is a different entity. In pure adhesive capsulitis frozen shoulder, it is a diagnosis of exclusion. You have ruled out joint arthritis, you have ruled out rotator cuff tear, and then basically the joint is kind of frozen. So you inject a high volume solution, which includes 20, 30, 40 ml of normal saline. Steroid is one of the most important component of the medication, and few ml of local anesthetic. So that the idea is basically with that high volume, you try to distend or rupture that capsule. You can feel a sudden loss of resistance. In the literature, it has been described from 20, 30 up to 50, 60 ml of normal saline has been injected by different people. So that is how you go for it. Once from the posterior approach, once you have injected few ml of medication, you can clearly see that capsule getting distended. Your infraspinatus will go up. You can clearly, the needle will be in between your articular cartilage and the capsule itself, and then you can keep on injecting some saline, 30, 40, 60, whatever you feel. I have not injected more than 40, 45 ml of normal saline. So that way you do the procedure. In anterior approach, I have never used more than 20 or 30 ml of saline. So what I have recently been doing, so anterior approach is very quick, easy. So I just took from the anterior rotator cuff interval and then immediately scan at the posterior part. You can see that joint very nicely distended once you scan from the posterior joint approach. And if you feel there is a little bit of resistance from the anterior approach, I just put my needle in the posterior glenohumeral joint and do the rest of hydrodissection, hydrodilatation using just that 10 ml needle, that 1.5 inch needle that comes. So that way, it has been found to be, from the literature, comparison between the only steroid injection into the joint with few ml of local anesthetic and the hydrodilatation, there is a bit of better outcome when hydrodilatation has been done. So that is exactly the question.
So I have one question, Sahoo sir. So if a patient of frozen shoulder comes to you and the severe restriction and the pain component is also more, so do you do the procedure stepwise? How do you go about it? It means how is the gap, or you do it at once? Means first you target the pain, treat the pain, and then do the mobilization thing, or afterwards, or how do you go about it?
Well, most of the patients, by the time they come to us, they're like 4, 5, or 6 months, and by that time they would have tried different medications. Most of the referrals are from neurology. I'll say 20-30% of the patients, they're like direct walk-ins, rest are like referrals. So by the time they come to me, they would have tried all the medication, including good trial of anti-inflammatory, opioids, and some neuropathic medications also, and some physiotherapy. So good number of them are referred directly for the procedure. So from the very beginning, if they have not tried anything medication, which is very, very uncommon, so I go for the procedure. The result, of course, very few patients, as you know, there are 3 phases, freezing, frozen, and the thawing. That freezing part, in the initial part where the pain component is more and the mobility restriction is less. So that time we see less number of patients. Most of the patients come 6, 7, 8 months down the line where it is kind of more of frozen. Pain will be there. Freezing. So that time pain is there, as well as they find it difficult to do household chores, coming, bathing, putting the shirt, everything. So procedure. Most of the times patients agree for the procedure because for me it is office-based OPD procedure. I don't have to take them to the OR. So they agree, take care, quickly done. So yeah, I go for it procedure from the very beginning.
Okay. Thank you. Any more questions?
So I think there are no questions right now.
Yeah, there are no questions now. I would like to.
But I would like to just mention, I'm Dr. Kirti Pawar.
Yes, ma'am.
Sanjog sir mentioned about the vasovagal incidences. I think in post-COVID era, this vasovagal incidences are increasing, what I feel. I'm practicing since 10 years and I never came across any vasovagal incidences post-procedure or during procedure. But I think this mask, anxiety, these are causing the vasovagal incidences more. What is your opinion? I'm asking every pain physician on this floor. Hello.
Yes, ma'am. Actually,
Archana, what do you think?
Yeah, yes, ma'am. Actually, ma'am, in shoulder procedures, especially in the sitting position, I think when we do blocks in the sitting position, patients are more prone to vasovagal. The other day I also had a patient with frozen shoulder, and I was doing a suprascapular nerve block for him, and he went into vasovagal. So we finally had to give him a lateral position, and then we did the block.
Actually, lateral position we can approach posterior, anterior, and we can do everything. So I feel.
My question is in COVID, this thing, mask and this thing, post-COVID, surprisingly the incidences are getting more and more.
No, I agree with Archana. If you are doing in a sitting position, then I have also came across, and the patient just collapsed that time. Collapse in the sense she had a vasovagal attack while doing the shoulder procedure.
Yeah, I have started pre-oxygenating the patients before doing any procedure.
Okay, ma'am.
Yeah, Archana, if there are no more questions, then I think we can conclude the session.
Okay, thanks again, Dr. Sanjog, for your wonderful presentation, and thank you, Sahoo sir, so much for coming and giving us your input, valuable input. I would like to invite Dr. Uttam Sidde sir just to conclude the session. Yes, so please.
Thank you all participants. About the ultrasound, we have seen the paradigm shift from the ultrasound. Initially, that was a mysterious instrument in the OT or somewhere, because we at that time 10 years back we were not aware about that gray, black and white images. Then we started giving some blocks under ultrasound. Now I am happy to see all the pain physician diagnosing it and then treating the patients. First of all, I would like to thank Rajendra Sahoo, a good friend of mine. I consider him as the Amitabh Bachchan of ultrasound, MSK ultrasound. for joining us for this SSPP meet. And he's a very good teacher. I've seen him teaching people, young pain physicians in various conferences. And I had that opportunity when I went to Mumbai also to learn from him, because I'm very new to ultrasound. I learned on the fluoroscopy. I also like to thank Sanjog. He's doing very good work and nice presentation. And even Archana, good moderation. So I'm very happy to see this program, because the ultrasound has a very big learning curve. So we need to conduct such kind of programs for especially for the MSK ultrasound. So thank you all, and thank you all the SSPP members for conducting this nice program on shoulder ultrasound. Thank you all. So we will meet next month, 3rd Monday, again for some interesting topic. And please join these SSPP meetings. We are going to conduct it regularly on every 3rd Monday from 8 to 9:30.
Sir, it's 4th Monday.
Yeah, thank you, Dr. Uttam.
It's 4th.
Yes, we will either see either 3rd or 4th Monday, depending upon the
3rd or 4th.
Yeah. Yes. So now we can say that we can conclude the meeting. Thank you, everybody. Thank you, the technical support team.
Thank you.
A wonderful job and wonderful start.
This was
thank you all.
Live on anesthesia.
Good night.
For thank you, ma'am. Good night.
Thank you, team Pune. All the best. Thank you so much.
Thank you, Rajendra.
So thank you.
Special thanks to Dr. Rajendra.
Thank you so much. It's a privilege to be
there. Is one Kamalasan. I call one Kamalasan is in Chennai and one Bachchan is in Bhubaneswar in MSK.
Very true, Uttam. Very
That's a little too much, sir. You're too kind, but that is a little too much. So there is only one Bachchan, only one Lataji. That's it. No one can come close to him.
No, Bachchan in MSK.
No. That's a little too much. Thank you. We're still learning.
So thanks a lot. Yeah, bye-bye. Good night.
Good night.
And we will meet in Bhubaneswar.
Sure.
Yeah.
Sure.
Bye and good night.
Bye.
Yeah.